My task this morning is slightly different from Nick's and Chiroc's. So I'm going to talk about really this. Okay, Mr. and Mrs. Smith, the quintessential American woman and man, right? Our dreams, our goals, our aspirations. This is unfortunately a myth because the reality is slightly different. Okay? Actually, let me correct that. It is very different. Okay. So let's look at the problem today. Today, in this country, more than a third of Americans, adult Americans, are obese. Now, to put that in perspective, imagine the percentage of white Americans in this country, Caucasian Americans. That's about a third. So if you go to a store, you go to the airport, go to any place you see, and picture an adult white male, then that is considered an obese person in this country. But obesity has to start somewhere. It cannot simply evolve overnight. Obesity starts in childhood. And in this country, 17%, close to 20% of children and teenagers are obese. Again, to put things in some perspective, this is the percentage of Hispanics in this country. So again, pretty large number of adults and children in this country are obese. Now, there is some argument saying that these numbers haven't changed over the last half a decade, and that's true. So there are not any more patients getting more obese, but the obese themselves are getting heavier. So we're seeing a lot more of the morbidly obese in this population. There's also quite a spread in terms of geography. There are some states and some regions. I'm proud to say that where I come from in Denver, we are fairly lean. In fact, in Denver, I'm somewhat an outlier. I'm kind of a heavy person there. But there are areas where you see that the prevalence of morbid obesity is rather high. Okay. That, of course, also involves this state here. Okay. I don't know what to do about here. So. A very simple concept I would like to convey to the audience, okay, is that sleep, obesity, and sleep apnea are interrelated. And let me prove this relationship with some very simple evidence. Does sleep or lack of sleep affect obesity? And does obesity itself create sleep disturbance? And the answer is yes. Okay. Over the past 40 years, at least in this country, the average nightly sleep duration has decreased by 1 to 2 hours. Okay. Which means that 40 years ago, the average adult male and female sleeps probably 1 to 2 hours more than we do today. Okay. Much more striking is that close to 40%, okay, sleep less than 7 hours each night. Now, 7 hours is important if you were to consider that sleeping less than 8 hours a day is associated with obesity. And that if you sleep less than 6 hours a night, not only is your risk for obesity increased, your risk for diabetes is also equally elevated. Again, 40% of us sleep less than 7 hours, and we are here right smack in this risk factor for both obesity and diabetes. What about obesity? Does being overweight itself lead to sleep disturbance? The answer is not quite as clear, but there's one study showing that an obese person has less sleep duration each night, and this person also has increased sleep disturbance during the night. So perhaps this is true. What about obesity and sleep apnea? Does obesity cause sleep apnea? Yes, we have that answer. In fact, obesity is probably the second most important risk factor for sleep apnea, second only to genetics. And it is the most important modifiable risk factor. Over 70% of sleep apnea patients are obese. Now, this is a very important statement because I was misquoted once when I was being interviewed by the Canadian FAA. what was printed was that I said that 70% of obese and overweight adults have sleep apnea, which is wrong. Okay. So again, if this room was filled with everybody who has sleep apnea, then 70% of you will be overweight. The more important question, though, is whether if everybody here in the room was obese, how many of us would have sleep apnea? That is more difficult to answer because of other factors, including age. You also mentioned heart failure earlier. This can all increase your risk for sleep apnea. So to look at that question, we better look at children, where the effects of age and metabolic syndrome and heart failure are much less. In one study, looking at healthy but obese children, the prevalence of sleep apnea is 21% to 40%. So if this room was filled with children, and all of us are healthy children, this half of the room will have sleep apnea. Pretty large number. If you look at a very old study, looking at the apnea index and body weight, you can almost see a almost linear relationship. And the reason is really quite simple why this is the case. If you gain weight, not only do you become wider outwardly, you also become narrow inwardly, and that involves your upper airway. Secondly, when fat infiltrates the muscle of the upper airway, it becomes more collapsible. Thirdly, and probably equally important, is that when we gain weight, it does affect our lung volumes. And if you think of the lung and the upper airway as a balloon with a stem, if you were to deflate the balloon a bit, then the structure of the stem, the rigidity of the stem will also be affected. Again, fat or being overweight really affects not just the upper airway, but also the lung volume itself as well. And if you are overly obese and you have this airway, it explains why you have sleep apnea. By the way, I took this picture when I was resident actually at Yale. I saw my very first sleep apnea patient, and I was so happy to see this. I called the hospital photographer to take a picture of it, thinking it might be rare, so I can submit it for a case at New England. And then I realized that no, this is really quite common. But I kept the picture. It is not simply general obesity that's important. Even more so might be central obesity, and we can measure that in many ways. We can measure that in terms of the waist-hip ratio or the waist circumference. And if you look at just these numbers, if your waist-hip ratio in men is more than 1, and in women it's more than 0.8, then your risk for sleep apnea is increased. To make it simpler still, if your waist circumference, if the belt you use each day is more than 40 inches, then your sleep apnea risk is elevated. What about sleep apnea? Can sleep apnea lead to obesity? So we know that being overweight can cause sleep apnea. The question now is whether having sleep apnea itself and treatment for sleep apnea, can they also increase weight further? The answer appears to be yes as well. And there are many factors that can do that. Sleep deprivation itself has been shown to increase appetite and caloric intake. Intake of salty, starchy foods is increased when you're sleep deprived. Daytime somnolence and its concurrent physical inactivity can also contribute to further obesity. There are changes in certain chemicals, leptin, ghrelin, orexin, maybe adiponectin as well, and insulin resistance and diabetes. Let me just explain to you one thing. You probably have seen this picture before. This is a mouse with leptin and a genetically altered mouse without leptin. Now, there are two important chemicals to remember. One is a leptin, and as a mnemonic, if you want to remember this, leptin, L, is produced in the adipocytes, or lipid cells, L, and levels of which will make a person leaner, lose weight, but eating less. And in sleep apnea, levels of leptin, although higher, activity is less too because of leptin resistance. So leptin L, liver cells, lose weight, leaner, lower activity in sleep apnea. Ghrelin, on the other hand, is produced in the stomach. So G, ghrelin, gastric cells, G, they make you gorge, gain weight, become ginormous, okay? And levels are greater in sleep apnea. So you see this, okay? So what happens in sleep apnea is that for whatever reason, which we still haven't really fully explained, levels of ghrelin, which makes you gain weight, goes up. And activity of leptin, which makes you lose weight, goes down. Okay? So here you have this balance. Have you ever met people who say, I have sleep apnea and no matter what I do, I cannot lose weight? Okay? And this may explain part of that inability to lose weight. Okay? If you look at this simple slide, looking at AHI and glucose levels, there's AHI severity, here is 5, mild, moderate, severe sleep apnea. And if you look at glucose in terms of fasting in a 2-hour glucose tolerance test, you will see that the fasting levels really are not quite different based on apnea severity. But the 2-hour glucose levels are increased. This happens despite an increase in insulin levels, again in the 2-hour test. Okay, here, see this goes up there, suggesting insulin resistance. Another study showing that if you treat patients with sleep apnea and insulin resistance with CPAP, that insulin sensitivity improves, okay? Even as short as after 2 days and clearly persisting after 3 months. 3 other important studies. Okay. It appears that sleep apnea obesity can increase your risk for diabetes. But diabetes too itself can also increase the severity of sleep apnea based on this study. Okay? And whether the apnea is mild, moderate, severe, that correlation holds true. The second important correlation is between sleep apnea and diabetes patients and treatment with CPAP. Okay? CPAP therapy does not simply improve sleep apnea, AHI, and oxygen. It also improves glucose control. In this study, there was a decrease in glycohemoglobin levels and also an increase in the patient's quality of life. And finally, we'll talk about metabolic syndrome, of which glucose is only one. CPAP has also been shown to decrease levels of cholesterol. Okay? And there are 3 important factors to consider here, is that the effect was much greater in those who are young, in those who are more obese, and those who use CPAP longer. So the lesson to learn here is that if you have somebody with sleep apnea, you treat them when they're young. Okay? You be more aggressive when they're obese. Okay? And really, they really have to use this and adhere to treatment. So we prove this as well. Okay? The next step now is a little bit more difficult. It is to, well, before I do that, I'm sorry, I apologize, I forgot this about this slide. I just added this slide, by the way. About 18 years ago, there was some preliminary data showing that if somebody uses CPAP, that this might increase to weight gain. And that was worrisome. And in the Apple study that was just published last year, it showed that CPAP use led to weight gain. Okay? The 3 important things this study showed. One is that compared to sham CPAP, so CPAP that was not therapeutic, compared to sham CPAP, CPAP users actually gained weight while the sham users lost weight. Okay? That's one. Secondly, the hours of CPAP use, okay, correlated to the amount of weight gain. Indeed, those who were most adherent to CPAP use, meaning those who use CPAP for more than 4 hours a night, more than 70% of the nights, our medical criteria for CPAP, were those who gained the weight the most. Okay? Now why? I don't know. I don't know why. Takes bigger minds, maybe Sharok and Nick can tell them. I don't know. Work of breathing. There are many reasons. Okay, Sharok just said that when you are having sleep apnea and you see them, they struggle to breathe each night. The work of breathing increases. Okay, so your metabolism increases. So that suddenly, if you were to maintain the same diet, the same lifestyle, okay, and you have to work less, then you gain weight. Okay. There are other arguments too. Is that people who are somnolent in the daytime may be sitting down watching TV in their lounge chair, doing nothing because they're sleeping. Suddenly, they're sleeping. They're sitting in the lounge chair watching TV, awake but eating, right? So a lot of things going on. Leptin levels may change too. This is more difficult. Okay. To correlate sleep, obesity, sleep apnea, and systemic inflammation is what I'm going to do the rest of the hour. I'm going to recapitulate some of the things that was mentioned earlier during the morning. Okay. This is a slide that you've seen by Naresh Punjabi, showing that if you were to follow survival and the apnea-hypopnea index, the two things are very clear. Is that a survival difference starts very early in the course of sleep apnea, and that there's a progressive difference in survival based on apnea severity AHI. So here you have somebody with AHI of less than 5, and here you have somebody in the red with AHI above 30, and you see there's marked differences in survival. But we have focused, I think, too much on AHI alone, because there are some studies showing that the risk for mortality in cardiovascular events is also related to non-AHI factors in sleep apnea. In this study, look at this. In this study, time spent with oxygen less than 90 is also important. Sleep time, 5 hours versus 6.5 hours is also important. Awakenings during the night is also important too. Periodic limb movements, which we rarely consider as important, was found in this study to be important from 13 versus 0, and then daytime sleeping. So there are other factors beyond AHI that we have to consider, which makes it terribly important that when we do survival studies in the future, that we take a look into other factors as well. You've seen this before. Okay. A friend of mine called this the smiley face of death. Okay, so I look at the face. Okay. And we've seen that sleep duration of more than 8.5 hours and less than probably 6 hours, there is an increase in cardiovascular morbidity and mortality. Okay. Even if somebody does not have overt clinically evident heart failure, cardiovascular disease, sleep apnea is damaging. There is subclinical myocardial injury happening. This is a silent disease. Okay. So even a person is healthy, if there's sleep apnea, you have to be concerned that underneath the very healthy exterior could be a heart that is being damaged ever so slowly. In this study, troponin levels were elevated in sleep apnea. And more importantly, the troponin levels, which is a marker of myocardial injury, was related to not just AHI, okay, in this study, high AHI, but also a lower mean oxygen saturation, as well as greater saturation less than 90% during the night. Okay. Again, you don't have to wait for heart failure to occur. Once a patient has sleep apnea, damage is happening each night they're asleep. We just discussed earlier with you. I won't spend too much time on this. There is a rule of thirds, we call it, which was first described about 30 years ago, which is true even today. We think that people with heart failure, 1/3 of them will have central sleep apnea, 1/3 would have obstructive sleep apnea, and 1/3 would have no sleep disordered breathing. Okay. But what we didn't know then, that what we know now, is that the presence of sleep apnea itself, once present in heart failure, also contribute to worsening left ventricular function. And that mortality in this group is about twice higher if left untreated. Okay. So in this one study by Wang, the mortality from untreated sleep apnea versus mild to no sleep apnea is twice higher. There was a slide earlier about the ARTS study or the CANTAP analysis, is that in central sleep apnea, once you choose optimal positive airway pressure setting, and once the patient is adherent to treatment, it does improve survival. We'll talk more about this tomorrow when I return for advanced PAP therapy. This is a very important concept to remember. Cerebral ventilation has been shown to, in this subgroup of patients with heart failure, especially severe heart failure, to improve ejection fraction. So this is the ability of the heart to contract. Has been shown to improve BNP, which is a biomarker of heart failure. Has also been shown to improve New York Heart Symptom Classification. And finally, fatal cardiovascular events at 1 year. They will all improve with cerebral ventilation therapy in those with severe heart failure. Cardiac arrhythmias also increased too. In a study done by Rina Mira, both atrial arrhythmias and ventricular arrhythmias were increased based on severity of sleep apnea. The good news is that once you treat them, the recurrence rate for AFib is dropped by half. Okay. Dropped by half with proper CPAP therapy. And the frequency of PVCs too is cut by about 60% with proper therapy with CPAP. So although we see that it causes risks, we also see that treatment reduces this risk for both atrial and ventricular arrhythmias. Ischemic heart disease is increased too. I'll make a very simple statement. This risk is increased independent of confounding factors of age, blood pressure, weight, and smoking, and that the risk is reversed with CPAP therapy. I'm not sure if you've seen this slide before. Sudden cardiac death has a circadian variability, and for most healthy persons, this will occur about now. Okay, so the highest risk for sudden cardiac death is between 6 in the morning and now. Okay, and there's no better place to have this today than here because we have Dr. Javeri and Dr. Nick Hill to help you. Okay, while I continue the lecture, they will be helping you on the side if you have heart failure. We also know that sleep is protective and that the lowest prevalence, or lowest incidence, by the way, of sudden cardiac death occurs at night between midnight and 6 a.m. This, however, is changed when somebody has sleep apnea. Focus your attention first on the green bars there. You will see that, again, the highest numbers are now. There's a second peak this afternoon. And the lowest really are at night. But once you have sleep apnea, the whole temporal profile changes. So now you have the highest levels now, guess what? During sleep. Blood pressure, again, I won't go into much detail. Studies have shown that sleep apnea increases systolic, diastolic blood pressure. It also changes the characteristic we call the dipping phenomenon. For most of us, if we measure our blood pressure throughout the day and night, we see a distinctive drop in blood pressure in the early morning hours. We call it a dipping phenomenon. Okay? And this is found in some studies to be cardioprotective. This dipping phenomenon is lost in sleep apnea. Imagine that. You have somebody who is struggling to breathe. Imagine this person is drowning, okay, struggling with every breath. How would the blood pressure ever drop? How would the heart rate ever drop? They will remain elevated. In a very early analysis of the data, again, I'm not sure this is true now, but just gives you an idea of the severity of the problem, is that for every increase in apnea event per hour, for every increase in AHI per hour, the odds of hypertension increase by 1%. And for every 10% decrease in oxygen saturation at night, odds is increased by 13%. Pretty significant. Okay. However, there are some recent studies which has thrown some confusion into the picture. And let me just call your attention to two very well designed, very well managed cohort studies, Wisconsin on one hand and Sleep Heart Health on the other, showed conflicting results. In the Wisconsin sleep cohort study, relative to an AHI of 0 at 4 years, the risk of sleep apnea increased based on apnea severity. Okay. However, in the Sleep Heart Health study, at 5 years there was no correlation at all between AHI and hypertension. Now, why is this the case? There are many factors that could be possible, but two important ones to consider is that the Sleep Heart Health patients were older than the Wisconsin cohort, okay, and they were probably less overweight than the Wisconsin cohort. Okay. So these differences may be important when we look at other studies into this topic of hypertension and sleep apnea. CPAP has been shown to decrease systolic, diastolic, and mean arterial pressure. This was a more recent study published just last year in JAMA. Okay. It showed that the changes in 24-hour mean, diastolic, and systolic blood pressures are mentioned here. This simply reinforces an earlier meta-analysis done by Bazzano of 16 trials published in 2007 showing comparable decreases in systolic, diastolic, and mean arterial pressure. Okay. Pulmonary hypertension, again, this was discussed earlier. All I want to say is that it is common. It is very common. And luckily, the level of pulmonary arterial pressure in sleep apnea alone is mild. Okay. But the important thing to remember too is that some studies have shown that CPAP therapy can improve pulmonary arterial pressures in this subgroup of patients. Stroke is increased. Again, it is bidirectional. If you have sleep apnea, it increases your risk for stroke. Once you have a stroke, your risk of sleep apnea also increases. Okay? And the mortality is worse in both patients. In one study looking at the carotid intima media thickness, okay, which is a risk factor for stroke, there is a correlation between the intima thickness and the apnea-hypopnea index. Now let's do a very simple experiment here. Those of you who can stimulate a snore, okay, if you can do that, some people can't, by the way. Okay, I was amazed by that. I thought everybody could snore. Okay, but if you were to put your finger right by your neck here and snore, you will feel a distinctive vibration on your fingertips. Okay, and imagine doing that 8 hours every single day for 20 years, and the amount of damage that may cause your carotid artery. That probably explains at least part of this. Okay. At least part of it. What my role the next few minutes here is to explain why this happens. Why obesity, diabetes, metabolic syndrome, and everything else that I mentioned in the first third of my talk correlated with the second half of my talk, which is your heart failure, hypertension, stroke, everything else. And I think to put things together, we have to look into the inflammatory biomarkers. I think, and I believe this is widely agreed upon right now, is that there are many mechanisms for cardiovascular disease in sleep apnea. Okay? And I mentioned all of them here. What's clear though is that once you have a series of sleep apnea, so this is a 2-minute tracing, this is 30 seconds per bar here, you will see that in this 2-minute tracing there is probably 3 instances of sleep disorder breathing. And we have always, as a profession, looked into the apnea. We have always emphasized the oxygen desaturation. Okay. What I want to discuss the next few minutes is this part here, if I can get my mark here, this part here where the oxygen normalizes at the end of the apnea. This part there is called intermittent hypoxia. When you have short cycles of oxygen desaturation with an event, okay, and then the patient breathes again and reoxygenates, that moment of reoxygenation is, we think, harmful. So, intermittent hypoxia leads to depletion of ATP, which is your energy source in your cell. This in turn leads to the production of reactive oxygen species when you reoxygenate. These are very bad. These are very bad players, okay? Because this can lead to a variety of reactions, some of which are protective, hypoxia-inducible factor being one of them, okay? Others being damaging, nuclear factor kappa beta being an example. Okay? Don't memorize this. This is a moving target. Every day we learn something new about this, and every day what we thought was truth has been sort of corroded by new evidence. But let me give you a snapshot of what we think we have today. Okay? Knowing that what we tell you today, I tell you today, may be wrong tomorrow. Okay? I just want to. Inflammatory adaptive processes leads to production of cytokines, adhesion molecules, CRP, VEGF. In turn, activates cells within the lining of the blood vessel, the white blood cells and platelets. Eventually, all of these activated cells leads to adhesion, injury, and cell death. Okay. So this is what happens. Like I said, when you have hypoxia, when the body has no oxygen or decreased levels of oxygen, it tries to protect itself. Okay, so you have a protective effect. Okay, and what happens is that the body tries to produce more red cells to carry the oxygen, erythropoietin. It tries to dilate the blood vessels, okay, so that it can allow more blood flow. And it also increases vascular endothelial growth factor. These are good. All of these things here are good. But at the same time this is happening, there's also a bad element forming in the background, the production of inflammatory cytokines. And I'll mention just 3 right now: tumor necrosis factor alpha, interleukin 6, and interleukin 8. If we had a balance of this, okay, in fact, if we had more protective than damaging factors, then all will be good. Okay, we have the good and the bad occurring simultaneously. But in sleep apnea, we think, and studies have proven this to be the case, is that there is more of the damaging nuclear factor kappa beta, okay, and less of the protective hypoxia-inducible factor, and that's bad. Okay, so although there are some protective effects going on, the damaging effects far outweigh the effects of the latter. Let's explore some of these effects. Okay. Cytokines, by the way, like I mentioned earlier, is produced by nuclear factor kappa beta and activated protein 1. And there are 2 classes. One is pro-inflammatory, examples being tumor necrosis factor alpha, interleukin 6, IL-8. Okay. And pro-inflammatory cytokines cause fatigue, sleepiness. So think about pro-inflammatory as pro-sleep. It makes you sleepier. In contrast, there are anti-inflammatory markers such as interleukin 10. They cause sleep disruption. Again, to remember this difference, think of anti-inflammatory as anti-sleep, sleep disruptive. But in addition to be promoters of fatigue and sleepiness, the pro-inflammatory markers too are good biomarkers for future cardiovascular risks. So measuring them will give us an idea of the risk for cardiovascular events occurring in the future. Nuclear factor kappa beta. Okay. If you look at the apnea-hypopnea index here and nuclear factor kappa beta levels, you will see there's a direct correlation. More importantly, this is control. This is pre-CPAP and post-CPAP. This study has shown that treatment with CPAP reduces nuclear factor kappa beta. However, as shown very clearly in this slide here, levels do not really quite reach levels of control. Okay. One important lesson to remember. What about C-reactive protein? You see this all the time in most papers. And again, the evidence is contradictory. There's lots and lots of studies showing that the C-reactive protein levels are increased in sleep apnea, okay, and that levels correlate with apnea severity, and that CPAP treatment improves levels of CRP. However, there are also other equally good studies showing that there's no correlation if you take into account obesity. Now, why is this the case? C-reactive protein is a pentraxin, and there are many pentraxins. Okay. C-reactive protein is called a short pentraxin. It's produced by the liver cells. Okay. And really, it's a very non-specific biomarker of inflammation in the blood vessels. Okay. On the other hand, pentraxin 3, referred to in some studies as the long pentraxin, is produced right where the damage is occurring, in the endothelial cells and the smooth muscles of the blood vessels. Okay? And therefore, for the purpose of our discussion today, it's more specific marker of inflammation. If you look at pentraxin 3 levels, they are increased with sleep apnea, and they do decrease with treatment with CPAP. Okay. The problem with CRP is also seen with interleukin 6. Again, there are some studies, earlier studies, showing that sleep apnea increased levels of interleukin 6, okay? And that CPAP treatment reduces them. However, again, the very same problem with CRP, they are influenced by obesity, both CRP and interleukin 6. Okay? So that there are some studies now showing that if you were to take into account BMI, the correlation is not seen. Let me show you one good study though. This is interleukin 6 levels before and during CPAP treatment. This is before and during CPAP level goes down. What was remarkable about the study though is that interleukin 6 levels have a circadian variability. They change over the course of the 24-hour period. So if you just took one spot measurement, let's say you took this measurement about here before CPAP, and let's imagine you took the next one here during CPAP treatment, then you will be led to conclude that there's no effect. Okay? So not only do you have to take into account other factors such as obesity, you also have to consider, at least in some of these biomarkers, a circadian influence in levels. Interleukin 6 study showing pre and after tonsillectomy versus control. Again, levels do go down, but somehow we're still considered higher than control. Interleukin 8 and sleep apnea. This is a study done by Campagnolo. HS stands for healthy subjects. OO, obese obstructive apnea. NOO, non-obese obstructive. And ONO, obese non-obstructive. Now what does this study show? The levels are lowest when you have healthy non-obese no sleep apnea. Levels do increase with either obesity or sleep apnea, but the combination of obesity and sleep apnea produce the highest levels. Okay. This is true also for ICAM, again by the same study, by the same authors. The combination of obesity and sleep apnea produces the highest levels of ICAM. Okay. Other factors. I mentioned vascular endothelial growth factor earlier, and nitric oxide as being protective as part of the hypoxia-inducible factor pathway. Levels of both are altered by sleep apnea, and levels of both are improved by treatment with CPAP therapy. Finally, coagulation. Okay. Sleep apnea can be considered a hypercoagulable state. Okay. There's ample evidence showing that the increased platelet aggregation, your platelets becomes more coagulable. Okay, therefore clotting forms. There's also increased blood viscosity. Recall earlier when I talked about hypoxia-inducible factor, I mentioned that in an attempt to increase blood delivery of oxygen, you want to increase red blood cells with erythropoietin. But that can also lead to polycythemia, which in turn leads to increased blood viscosity and thickness. And then finally, levels of coagulation factors are increased. Everything from thrombin complexes to Pi1, they're all increased with sleep apnea. The good news, again, good news that I've been sharing the whole morning is that treatment with CPAP reduces levels of fibrinogen. Treatment with CPAP reduces PI1 activity. Again, there is a common thread here in the discussion, is that you will see a lot of biomarkers being increased or altered by not just sleep apnea, but other confounding factors such as obesity. And most studies shows that with proper CPAP treatment, the levels do improve. They do go down. So you're doing good. So even in the patient with subclinical cardiovascular disease, which I showed you earlier is quite common, somebody without heart failure, somebody without overt stroke, somebody without overt ischemic heart disease, every single night that they're having hypoxia, every single night that they reoxygenate to breathe again, you're causing inflammatory damages. And every night you treat them with CPAP, those markers go down. The biggest challenge, though, is that it appears that even with CPAP treatment, and in this case, tonsillectomy, there's also evidence on oral device, and I'll show you later on, is that levels never really reach levels of normalcy. Okay. So there's something that's missing here. Investigators today across the globe, a lot of them in Asia, are looking also into anti-inflammatory drugs, okay, to complement CPAP therapy for these conditions. It's too early to tell you what those effects will be. But what I need to emphasize today is that we have to be clear that CPAP therapy, although very good in reducing sleep apnea, are not quite as good if you look at the other adverse effects going on in these patients. This is what I wanted to show earlier, is oral devices. Okay, very rarely do you see an oral device study looking beyond AHI, but this is one study showing that after 2 months of the oral device use, that in patients with severe sleep apnea, endothelial function improved. Okay. Remember your nitric oxide levels here? They didn't improve. And the flow-mediated dilation, the ability of the blood vessels to dilate, also improved with the oral appliance. Okay. So, to conclude, although sleep apnea has been thought of primarily as an upper airway problem, leading to arousals and therefore sleepiness and fatigue, leading to hypoxia and therefore leading to cardiovascular damage, there are other mechanisms involved as well. Okay? And we ought to think of sleep apnea as a systemic disorder. Again, I haven't even discussed other consequences of sleep apnea, right? I haven't even discussed cancer risk, or dementia, depression, or reflux, or liver dysfunction, or glaucoma, or nocturia, rectal dysfunction. There's many things going on. But looking at simply the cardiovascular and pulmonary disorders, we have to think that there's something going on in terms of oxidative stress, lots of inflammatory markers going on, it's truly procoagulant, there are effects on the metabolic syndrome in terms of both causing changes in leptin, ghrelin, and insulin, and finally, it causes atherosclerosis. Thank you.